Welcome to our IDRPP-USU Substance Use Echo. My name's Leo, and I'm the project assistant for Project Echo up here at Utah State University's Institute for Disability Research Policy and Practice. If you could please drop your name and contact information in the chat, it would be appreciated. This just helps us network with each other and helps us contact one another if we have an idea or resource that we want to share with each other. We are recording today's Echo session for educational and quality improvement purposes. So when joining and participating in this session, you are consenting to being recorded. So if you don't wish to be recorded, please disconnect from the call now. Echo is a participatory interactive community, so we have our presenters, our stakeholders, and community members all communicating and supporting each other during a session. Participants are expected to be engaged in asking questions after the didactic presentations. Questions are also welcome to be dropped in the chat, and we can get them answered after the didactic. Case narratives and discussions are also a great way to get support on difficult cases that you may have, and it gives you strategies that you can apply in real world situations. So if you haven't presented a case narrative, I really urge you to do so. And if you are considering to do so, you can email projectscope@usu.edu and we can get that set up. Let's also to remember to please protect individual privacy. We do work with some sensitive topics, so please take a moment to de-identify those situations. And if you are unsure about a statement or question, you can always reach out to one of our hub members who should all have asterisks by their name. Oh, that's a hard word to say. The hub member moderating today's chat is Janelle Preston, so they can address those concerns, comments, or questions that you may have for the presenter. There are three key components to an echo session. The first for today will be our didactic speaker, who will be Amy Parker, presenting on Odyssey House's Parents with Children Treatment Program. Our second key component is our case presentation, which today will be in the format of community questions. And our last component is the professional networking, which can happen in our breakout rooms by reaching out to someone in chat, etc. Echo sessions are just a really great way to network with others from similar organizations and get some really great ideas. Also, please rename your profile to your first and last name, state, job title, and organization if you already haven't done so. And if you don't know how to do that, you can click on those three dots by your name and navigate to the Rename tab. And this is also how to raise your hand. The raising hand function is really helpful if you don't want to interrupt the person that's speaking or the presenter that's speaking. I think it's a really great function to use. It's located in the Reactions tab. And then just to go over some quick etiquette in our echo sessions, let's remember to please respect the presenter by using chat or raising hands to contribute when the presenter is speaking. Let's also keep our questions brief and on topic as it helps everyone get into the conversation. And if you could, please introduce yourself and your organization before asking a question. And last, we do encourage you to turn your camera on as it helps us connect over this virtual echo session. And how to get credit for attendance. Tori will be dropping the survey link to get that credit of attendance, and that credit is presented in the form of a certificate of attendance. We value your feedback a lot, and we always use those survey results to improve the quality of these echo sessions, and it also lets us know how we can help you better. We also have a place in our survey that asks for an email, phone number, and mailing address. That's just so we can send you some free merch. So if you'd like free merch and you leave that option blank, you can fill that in and you might get some free stuff. Also, I'd like to plug our Canvas page. Canvas is the platform we use to put resources from today's session and past sessions for you to access. If you would like an invite to our Canvas page, please email projectscope@usu.edu and we can get that invite sent over. Also, here's another plug for case studies. They're just a really great opportunity to receive really valuable and applicable feedback to some hard cases if you are going through that. And also make sure that you're following USU IDRPP Project Echo on our social media pages. We have a Facebook, Instagram, a LinkedIn. This is where we just post updates and reminders. We also post information, quotes from our sessions, and these pages are just a good way to stay connected with one another. We also have a Facebook group where you can continue discussions after sessions. You can receive updates on all of our upcoming sessions, and it also is a great way to network with others from similar organizations. Awesome. So now I'm going to turn the time over to Amy.
All right, let me pull my slides up here and share my screen. There. Leo, can you guys see my screen?
Yeah, it's perfect.
Hi, everyone. My name is Amy Parker. Hopefully you're all here to hear about Odyssey House Parents with Children's program. We are a residential treatment program facility in Salt Lake City. I am an LCSW and an advocate for child abuse prevention and people in recovery. Our mission with Odyssey as a whole is empowering people to heal and build better lives. I've been called by Echo to engage in some action to inform you all here on our program in hopes in supporting you in knowing a resource that's available, as well as collaborating as a community to support our most vulnerable population. So for us, that would be people who are in recovery, actively using substances, and children. So, oh, perfect. Um, so why are we all here? Well, substance use has an astronomical impact on families. We may see things such as attachment tears with children, separation, relationship deterioration, trust barriers, homelessness, domestic violence, neglect and abuse, both within the children and their parents. Isolation occurs during substance use and discontinuation of engagement with sober, supportive relationships. Employment barriers, DCFS, probation, incarceration involvement, and obviously our most largest death, overdose, and trauma. So, to provide some examples of this impact versus just labeling it, I want to give you some statistics of what has been seen, and sources are all listed at the end of my slideshow. So for those who want to look it up a little later, I will have those accessible. When family members are actively using substances, we may see separation and attachment tears due to leaving to use, right? So they're leaving their home, or they're locking themselves in rooms to use, or they're going to places to actively use outside of the source of their home. We may see DCFS removals, so the child being separated from their parent. Incarceration times, whether that is short-term or long-term. We may also see child abandonment as the family member isolates, promises that may go unmet to their children. These may include, like, I'm going to stop, I'm going to quit, or I'm going to do this, or so on and so forth. As role changes may change as well. So we may see children taking on the care of their parents, or parentified children where they are taking on the care of their younger siblings, or things of that nature that also further develop some of those attachment tears with their parent. We see relationships that deteriorate and trust diminished, whether that is in a quick fashion or a more long-term deterioration as continued use or dishonesty presents itself. As familial resources or friendships try to step in and support their loved ones, boundaries are held. And the individual may find themselves homeless or without financial support. Substance use in of itself is a financial burden. They may find their home can become an expendable expense to further support their substance use. We often see background checks and evictions impacting those in recovery, preventing them from having access to housing opportunities, and potentially continued maladaptive behaviors to survive. Employment barriers may be seen through stigma and discrimination due to poor work history. So low skills, low education due to substance use, or even interruption to their educational development. As for a lot of our clients, Substance use may start at a very early age. I've seen substance use, I think at the earliest age personally, at 6 or 7. Obviously impacting brain development and educational support. Criminal records and background checks can disqualify them from employment opportunities, or open probation requirements can disqualify them from employment opportunities as well. Um, when we are thinking about this as a system, it impacts a client's ability to financially provide for their families, further perpetuating staying in situations that they would otherwise probably leave. Around 40 to 60% of reported domestic violence situation involve alcohol or drug use, according to the American Addiction Center. Research has indicated that up to 75% of individuals who start treatment for a substance use disorder have reported engaging in assaults, muggings, use of a weapon to attack another person, or other violent crimes. According to the National Institute of Health, 1 in 4 U.S. children have lived with at least one parent or a primary caregiver who has a substance use disorder in 2023. So in the fiscal year of 2024, to further conceptualize Utah's experience of this, 829 children were placed in the foster care system in the state of Utah based on being affected by substance use. 244 of those were placed with a parent in a residential substance use treatment program, just like ours, according to the Department of Health and Human Services. The Utah Department of Corrections reports in 2023 that 1 in 12 Utah children have a parent that is currently incarcerated. And they are also 6 times more likely to become incarcerated themselves. Thinking of the school to prison pipeline. As the nation has, as a whole, has experienced a 24% decrease in drug overdose, Utah is not one of those states. They are 1 of 4 states, including Alaska, or 1 in 5 states, including Alaska, Montana, Nevada, and South Dakota, where we've actually seen an increase of 14.3% in 2023, with 606 Utah resident deaths from substance use overdose. The impact of substance use on families is not something our communities can sit idly by. Utah children and their families are obviously suffering. So that leads to, when we know what that impact is on families, we are enacting our mission to empower people to heal and build better lives. We hope to make a difference in some of these statistics. So our program is obviously the Parents with Children's program. We're located at 42 South, 500 East, up here in downtown Salt Lake. We are a 16-bed facility serving both mothers and fathers in Salt Lake City, but we also network outside of Salt Lake and take clients as far as Vernal, and up into Logan and beyond. We also are the only fathers program west of the Mississippi. So that means that we are the only program that takes males. We serve children from birth. So we get our pregnant moms that may come in and they may birth their children here with us, all the way up to 11 years old. We staff children over 11 to assess our ability to meet their needs and appropriateness for our programs. As we know, when we start to head into 12 and 13, technology and access to sports or school and internet and things of that nature become a bigger priority, and we are not able to meet some of those needs given our population and access. We do not have a kid max for our program. So what I mean by that is a parent can come in with as many children as they have. We do have a 35 kid limit. So that means in total, we can only accept up to 35 kids in our actual program. We still have the 16 beds for adults. We have Family First licensing, which allows us to actually act as a foster placement for kids that are in foster care and, DCFS custody. And when the goal is to have, when their parents transition to outpatient, that they are transitioning in the custody of their parent and no longer in the custody of the state. We are a co-parenting, so all of our clients who are present in our treatment program work as co-parents. So each one acts as a parent and they support each other's parenting styles and navigate when there are discrepancies between one another. We are also a therapeutic community model treatment program. We operate on a small team of 21. So we have 2 therapists that see our adults. We have a registered play therapist that sees our children. We have a clinical director, a program director who is myself, a case manager who oversees all of our clients, 2 program managers, 4 wonderful teachers, and 7 behavioral health techs that support on evenings and weekends and literally are a blessing in our lives so that we can have time off. Within that team, we have LCSWs, CSWs, CMHCs, registered play therapists. We also have an APRN who is present in our program. We have multiple child development specialists who have bachelor's degree level education in family studies. We also have a peer support specialist. I can honestly never speak more highly than having a peer support specialist in a treatment program to meet the clients where they're at, and a medical coordinator so that we can make sure that our clients are receiving the medical care that they need. Our program has experienced significant barriers, and in communicating with some of our other parents and children's program within the state of Utah, we are seeing very similar responses from them that we're receiving parents later in their DCFS cases, which makes it more difficult to put reunification on the table. Barriers towards fathers being reunified with their children when mother is not able to be reunified. However, despite this, in our fiscal year 24 quarter 4, 75% of our parents that did have DCFS involvement, 100% of them were discharged with their parent as in their parent's custody at time of discharge, and 100% of them were sober. According to the Department of Health and Human Services, in the state of Utah, 78% of children that were placed with their parent in a residential substance use treatment were reunified with their parent at closure of their case. Further extenuating why these programs are useful, why they matter, and why we need more. And in comparison to some of our other quarters, as quarter 4 for us in fiscal year 24 was obviously a very successful quarter, some of our other quarters, we hover around 78% and above, with children being discharged with their parent and still 100% of them being sober at time of discharge from our program. So, family-centered treatment, what is it that we do behind these doors that hopefully is making a difference? We offer both services for the individual as well as services for our kids separately. And then we also offer services for the family unit. We offer In with Kids groups where parents engage with their children in structured theraplay activities. We're really focusing on attachment repairs, especially with separation time, children building trust with their parent, that their parent's going to follow through, validate their feelings. This time is also where our therapists can observe and engage in hands-on support in addressing, attachment between the parent and children. Our family therapy with our registered play therapist, Troy Cooper, who is the most amazing human ever. They meet with them as a whole once a week, but Troy may also offer therapy to the parent and individual children. We tend to see parents that have more attachment tears and repairs that need to be made with an older child versus a younger child. And so we may offer some additional services each week to that specific family unit. We also offer family time, where the parent and child have time set aside each evening to spend together, where there's not any other services that are being provided at that time. They focus on reading, cuddling, playing games, arts and crafts, and other activities that meet the level of development for that child. That may be tummy time for an infant, and board games with an older child. We also offer recreational activities on our weekends that the clients plan for themselves for their children. So they go to the planetarium. The zoo has probably seen us more times than they can count. Disney on Ice, they went this past weekend. We have been to every museum that Utah probably has to offer. We go to the parades. They had a really fun experience at Lagoon this year. Splash Pads and USARA, who's a community partner of us, hosts a lot of family supportive events that our clients go to as well. Our parents get to learn how to plan these events. As you know, if you're trying to get out the door with a child, it is not the same as being able to pack up as a normal adult. And I see a lot of head nods. So they learn how to prepare, like packing lunches, making sure they're going to have enough diapers, making sure they've got wipes and entertainment for the travel to, wherever they're going, making sure they have the funds available to do so. We fund it for these events, but they actually have to plan it out and navigate what the cost is going to be. In talking about our kiddos receiving individual therapy weekly, we focus on play therapy, sand tray, trauma-focused cognitive behavioral therapy, and attachment-based therapy modalities in hopes to build those relationships into a more positive space to build some trust. We have kids that come in that during our In with Kids group where we are assessing for attachment that child will play with any other adult other than their parent. And we get to watch them progress as they build trust that their parent will meet their needs and validate their emotions, that they will gravitate from the other parents towards their own parent as this space of trust. And it's wonderful. We offer parenting groups 2 times a week. So they're looking at 5 hours of parenting groups specifically from us. Like I had discussed earlier, we also work with USU. They have a co-parenting program that comes in that works with some of our parents as well. So they may get some additional parenting support in that regard too. Clients learn all things parenting, such as psychoeducation on attachment styles. If you haven't heard of the ACT model of providing choices, that is the model that we use to support parents in engaging with their child on providing choices, setting limits and boundaries, and following through with those boundaries of the consequences if a choice is not made. They work on role playing, learning about child development, ACEs, which I'll talk a little bit more about, co-parenting, space to process their own parenting styles, and the parenting they received as a child. A lot of our parents are working to navigate undoing some of the parenting that they learned from their own parent. That way we can support them with, and their therapeutic community can support them with parenting behavior interventions to reduce abuse and neglect of their children. So we may have a parent that comes in that is accustomed to spanking or slapping or corners or things of that nature, and their therapeutic community will wrap around them and provide them some interventions that alongside psychoeducation on how to support that parent with engaging with their child and getting them to accomplish what they're after without having having their physical body as a way to punish. Corporal punishment is not a parenting skill that we support in our program in any way, shape, or form, and is met with behavioral interventions and potentially discharge. We offer move-in adjustment time when clients are reunified with their children. So if they've come into the program and reunification is put on the table and they start the actual move-in process, we typically start with, short visits, moving into bigger visits, moving into an overnight, and then eventually moving in. We offer them time to get their child settled in our program. We're taking them from one environment into this brand new environment that they've never been in, and they need some space to process this. And they're moving in with people they probably would have never chosen to move in with, right? 16 other parents and all of their children at the same time. We also offer 2 weeks of maternity leave where a client's able to attend groups if they would like. Some of our clients struggle with isolation, so they may want to fully engage in groups during their maternity leave. But we also offer them the space to have private bonding time with their child, supporting skin to skin, breastfeeding, fed is best, whatever that looks like for them. When clients transition to outpatient, we also offer what we call goodbye circles. So we are teaching them to express closure, process grief as their peers leave to, their new treatment journey experiences. And our kids get to engage in goodbye circles as well. They make a lot of really close friendships, and it can be really hard to see, their friends leave, even though they're excited for their new journey. Our kids are provided with a signed book of Oh, the Places You Will Go, which I'm sure most of you are familiar with, that their teacher signs and the treatment team signs. And we've had a multitude of kiddos that have come back as adults expressing praises related to their experience at our children's services, and feeling like this has been a place that they could trust and felt safe during a really unstable time in their life. So, trauma-informed care. We are focusing on creating a healing environment and emphasizing principles like safety, as I mentioned, trust, worthiness, collaboration, empowerment, and making sure we're addressing cultural sensitivity. Our goal is not to re-traumatize our clients, but help them to build resilience, coping skills, and I'm going to talk more about ACEs, but ACEs in of itself supports our need as a community to provide trauma-informed care practices within our programs. The Adverse Childhood Experience Study, ACEs, is a guide to our need for trauma-informed care. our average ACE score at our program has historically sat between 6 and 8. Our program actually has the highest ACE scores out of all of our programs, including our mental health programs. For context, for those who may be unfamiliar with what the Adverse Childhood Experience Study is, it's a study that was performed that scored from 1 to 10 on traumatic events, such as neglect and abuse that a person experienced during their childhood. A higher score is indicative of greater risk of both negative health outcomes. These include substance use, heart disease, and cancer. A score of 4 and above, so as I mentioned before, our scores sit around 6 to 8. A score of 4 or more increases, doesn't guarantee, things like pulmonary lung disease, it increases it by 390%, depression by 460%, hepatitis by 390%, and suicide attempt by an astronomical 1,220%. This was discussed in the Kaiser Permanente study who ran the ACEs study. This, of course, leads programs like ours to meet clients where they're at, which means their trauma comes with them to treatment. The pictures that you see on my slide here is of murals that are throughout some of our rooms to create obviously a less sterile environment, a welcoming space. We get input from our kiddos and parents on what they would like to see in their environment, and these are some of the choices and ideas that they brought to the table. So trauma-informed care continued. So we're taking a look at the key components of trauma-informed care, as I mentioned before: safety, trustworthiness, empowerment, collaboration, and cultural humility, with the goal of improving mental health and substance use outcomes. We consistently work on creating a trauma-informed environment, focusing on those key components. We do this through a multitude of ways, like having a client space ready when they arrive. Our admissions program will give us a heads up that a mom's coming in with a 2-year-old and a 7-year-old, and we'll get that space ready for them. Their bed is welcoming. They have their towels. They have showering items, toothbrushes, and things of that nature that help support them feeling welcomed. We welcome them at the door. We assign them a behavioral health tech to support with their first 2 weeks. So this is someone that they can go to for guidance, questions, navigating treatment, and what to do, because this environment can be really overwhelming. After their 2 weeks, we assign them to what we call a upper house, which is an individual that is more seasoned in the program that can continue to guide them as a peer. Safety rules. So for our program, to support a trauma-informed care, we address these through making sure we have rules around violence. So practicing and utilizing I feel statements. When we're using our words, we're not using our hands. And consistent schedules. So they know what to expect through treatment expectations. It provides space for stability, consistency, and clear boundaries. Clients are encouraged to take space when they need it. When they find themselves outside of their window of tolerance, we have space for them to be able to go get back into their window of tolerance, come back into groups or sessions to be able to re-engage. Excuse me. We also offer the ability for our clients to bring their grievances to staff through I feel statements. So they come to our staff meetings, they tell us how we've impacted them, and they are met with understanding, empathy, support, commitment for change. And we are not above mistakes as well, right? Like, we are all human and we bring our stuff to treatment too. So, making sure that we're validating and meeting clients where they are at and being really honest that sometimes we're bringing our stuff to the table too and apologizing when we are. We have 6 cardinal rules in our program to support safety. They include no violence, no boundary crossing behaviors that include, sexual relationships with peers, child safety, stealing, no drugs or contraband, nicotine products or, money can potentially lead to discharge in our program. We are also working on trustworthiness in our program. We are transparent about the court reports that we send out. So we're making sure that we are writing our court reports, sharing them with our clients before they're sent out. That way we can create a space of transparency, trust, and collaboration. That way they can give feedback of maybe that isn't quite what that looked like. Or we have to have some of these really frank conversations that is what that looks like. How do we make improvements on that? Instead of they go to court finding out that you put something on a court report and breaking that trust and that collaboration. Our program also does not restrain adult clients. So we do utilize safety hugs on children only if they are harming themselves or physically harming another. It is also expressed through staff boundaries and making sure we're minimizing different responses from staff members. So we are making sure we're collaborating as a team, that if you ask one person one thing and you ask another staff member the same thing, they're going to get the same answer. Collaboration at our program is expressed through clients having a say in their own therapeutic interventions of both themselves and their peers. We're a therapeutic community model. And so when we can take it back to the community to have them do that work, our therapists are focused on being the rational authority of the room, making sure that things are not getting out of control, but that the clients are actually doing the majority of the work. Cultural humility. So at our program, it is seen at a multitude of ways. So if we have clients that have dietary restrictions, both due to physical health, but also religious. If we have clients that are unable to consume pork, which we frequently get, our entire house goes pork free to support that individual, to make sure that there's no cross-contamination, to make sure that that person is not feeling pressured to eat things that goes against who they are and what they believe. Cultural humility also for us means that we are not seeking to be competent, but we are seeking to be a partner and learner and reflecting on how our own backgrounds impact our clients. We may have a client that can't eat pork based on their beliefs, but they may not follow through with all of the religious beliefs related to that culture. And so we honor what and where they're at. The benefits that we see from navigating this trauma-informed care is mental health and positive mental health and substance use outcomes. So when people feel safe, empowered, partnered, and respected, obviously they're more satisfied, right? Don't we all feel more satisfied when people treat us with safety, empowerment, and respect? And they deserve no less. It also improves our staff satisfaction. So when our clients are feeling satisfied with the services that they're receiving, our staff naturally feel satisfied in the work that they do as well. So we know that this work and working in substance use and child welfare, and the current world situation we're in right now, it can feel never ending, or that there's so much that we need to address as a society as a whole that we can get burned out really quickly. And so when we feel as a staff that our clients' needs are being met and that we are supporting them and empowering them, we are naturally happier and reducing our own burnout. That way we can feel like we're making a difference, making some progress. Meeting our clients' health needs. So our clients both have physical needs as well as dental and vision. Meanwhile, we're maintaining their mental health needs through therapy services. So we are also working with our Martindale clinic through Odyssey House. If you were unaware, we have our own clinic. We work also with the University of Utah. They have a pediatrics unit that sees our kiddos, and they also see our pregnant moms through the Super Rad clinic, if you're unfamiliar with them. We work with Intermountain Healthcare, a lot of specialty clinics, urgent care and emergency room services are really familiar with us. We also have dental and vision. So All Smiles Dentistry, Sundrop Dental, Moran Eye Center, and Eye Care for Kids are really familiar with working with clients who have substance use disorders and being really supportive of navigating some of their health concerns without providing access to narcotics, which can be a huge barrier. We also receive support from a full nursing staff. Like I mentioned earlier, we have an APRN that comes in and sees our clients in office, which is wonderful and provides, the medication that they may need. We also work with Project Reality for the methadone clinic to support our clients that have medication-assisted treatment through them. Here are some adorable photos of our children's services. So taking a look at the upper left corner, that is the playground where our kiddos go outside when they're down at our children's services. We also have a smaller kiddo area for our toddlers. Up in the right-hand top corner is our toddler room and our preschool room below it. This is where our amazing teaching staff do their end of their work, and our parents get the opportunity to learn how to communicate with their children's teachers. So passing feedback forms and our teachers providing feedback of how their kids did all day so that they know, did their kid have quite a few tantrums? Were they having diaper blowouts, or are they feeling unwell, and things of that nature? That way they're prepared when they engage with child care centers in the community. We also provide through Miss Jamie Boone, who is the program manager over our children's services. She teaches them how to interview child care centers so that they learn how to spot some of the shady ones, the scary ones, or the ones that are not going to provide the most safety and transparency for their children. So a little bit about our therapeutic daycare. Our children go to either children's services or school when school is in session. After their first group that starts at a whopping 7:30 in the morning, Monday through Friday. So we are early birds around our parents program here. And our parents engage in programming till about 4 p.m., where they then go pick up their kiddos from our children's services. And our children's services also operates out of a trauma-informed care model through stability, consistency, boundaries, empowerment, and collaboration. They are focused on our 6 domains of development, such as language and literacy development. For our kiddos that aren't quite speaking, they work on sign language and sounds. We work on executive functioning, so focusing on the development of skills necessary for learning, such as self-regulation, attention and persistence. Social and emotional development, so being able to develop relationships with others, and learning to validate and empathize with their peers. We also work on physical development, so strength, stamina, and knowledge around leading a healthy lifestyle. We work on cognitive development, so throwing balls, riding bikes, scooters, jumping rope, things of that nature. We're taking a look at creative expression. So making music, drawing, coloring, all the fun stuff that kiddos really enjoy and get to express themselves in their own way. Um, Fun fact, Odyssey House has two other parenting programs in the United States. Those are located in Louisiana and New York City. The remainder of our programs are all adult programs. There's some in New Zealand, and scattered all over the United States. Although we operate from a very similar model, we are not directly related in ownership. So, what does a week look like for some of our clients? It looks like relapse prevention groups 3 times a week. It looks like specialty groups such as self-esteem, body positivity, DBT, boundaries, grief. They're getting that at least 1 time a week. Effective communication groups 2 times a week. We're taking a look at seeking safety to address PTSD. They go to Fit to Recover every Friday, which they race to get out the door. They love Fit to Recover, and we love them as a community partner. Employment and vocational training skills, they get that 3 times a week. Moral recognition therapy for our clients that have probation involvement so that we can support some of their court mandated requirements as well. They get individual therapy for a minimum of 1 time a week, and they can advocate for more if needed. We also offer time management skills groups 7 times a week for 30 minutes. So as you can imagine, our parents are busy. They, right? I see some midnight. They are busy. We are keeping them very structured and stable and getting them the resources that they need to hopefully maintain recovery long term. So, what are some competencies? Like, what are we hoping that they learn? When our clients are first coming in at that orientation level, that's that we're just trying to get them to stay for the next hour, the next minute, the next week, keeping them grounded, keeping them in treatment. For most of our clients, maintaining, keeping them in at this orientation level, this is their most critical time for relapse and leaving against clinical advice. So we want to wrap around this group as much as possible because for some, they may come in detoxing. They may not even have a minute of sobriety under their belts. As sobriety is built, they may move up to our compass level where they're learning about their thinking errors, automatic thoughts. We're teaching them to learn about their behaviors and triggers and whatnot. They're also continuing to learn additional coping skills and actively practicing them. At the discovery level, this is where we're starting to dig into the trauma work. They've got some coping skills under their belt. We can start having those discussions about trauma because a lot of our clients are here because of that. We got to navigate how to face that and work through it in a healthy manner so that we can make sure we can manage triggers and keep them sober long term. Then we have our wonderful navigators. These are our clients that are getting ready to transition to outpatient. They're working on their safety plans for transition. They are our leadership here in our programs, and they are role modeling that leadership behavior in hopes that the compasses and discoveries will step into their place and orientations will be given the hope that they too will be able to navigate this. So, where do they go after they leave here? Right? They can't live with us forever as much as we cherish and care about them. So, we have the only family sober living in the state. We also work with Life Start Village, the FUP program, so Family Unification Program. We work with HARP Housing, and our case managers scour Utah for any additional sober living arrangements that might be available. We also work with numerous community partners. You guys are one of them. USARA, Fit to Recover, Child Abuse and Prevention Utah, Smart Steps, Voc Rehab. Huntsman and Utah Clean Slate, and I could go on and on about the community resources that we have. So, how can you help? Um, some of you are already coming into our programs. You are working hands-on with our clients, providing support to them. You are advocating for social justice, working on stigma and barriers towards engagement, supporting with housing and employment, and um, even just talking to someone about our program or programs like ours is how you can help. We have people that come to our doors or people that I interact with that were like, I had no idea that you guys took dads. So we have dads that are potentially sitting in prison, incarcerated, or separated from their children because they are unaware of our program to have access to. So awareness is key, and we really rely on word of mouth and support. Um, I know I am running out of time, but I want to make sure you have access to our YouTube video of our single parent with children's program for you to review. It's about 4 minutes long, but I also want to make sure I leave time for questions here as well. So please feel free to watch it and learn about our clients and some of the benefits that they've gained from being in our program. I appreciate you all being willing to hear me today, and I am open for questions.
Awesome. Thank you so much, Amy, for presenting. I'm sorry, I'm having a lot of technical difficulties, so my camera isn't working. But I mean, you guys can see my profile photo, so I hope that's okay. I really appreciated your presentation. I really thought it was interesting how you laid out how you guys are doing family-centered treatment. Instead of just telling us that you're doing it, you're telling us how you're doing it, and you're showing us a lot of those strategies that you guys are implementing. So I think it's really wonderful, and it's a great resource for everyone in this network to know about. Then I see that Janelle has her hand up.
Yeah, Amy, I just had a question for you, especially where you were talking about some of the therapeutic programs for the children that you have. Um, I am in my other world a Part C early intervention provider, and so that I'm always thinking about how can we support you guys or the families that are in there. And so my question is, do you ever make referrals to your Part C early intervention providers? Or did they also come in and provide the family coaching to help with that, those that might be at risk for a developmental delay or disability?
Yeah, so we work with DDI Vantage. They come in with our kiddos and parents and work with them hands-on, one-on-one. And we provide open access as long as we are also meeting DCFS's very strict expectations as well of what that child also needs. We work with Child Abuse and Prevention Utah, so they come in and actually provide direct feedback to the parent while engaging with the child. So they're watching the parent and child interact, and then they're like, well, why don't we like try it this way? Or how do you think that might have went if we tried it this way? Or why don't you give this a try? Or, in my experience, if we try this, and our clients are really receptive to those responses. And a significant amount of our clients have coaches through Child Abuse Prevention Utah and DDI Vantage as well. We welcome you guys to come into our programs. Absolutely.
Great, thank you.
And then I'll just leave a few more seconds or like a minute for some questions maybe to come in through the chat. I also had a question. I know a lot of the times, a lot of organizations similar to yours face a lot of stigma throughout their communities. So what's the kind of stigma that you faced, if you have faced any so far, and how have you guys worked to combat that?
The biggest stigma that we face is that what is presented to us is that a parent is an unfit parent because they're in substance use treatment. And we get that from guardian ad litems, prosecuting attorneys, especially on the DCFS cases. We hear it from judges. And the way that we combat that from our program specifically is for when we identify that those clients are being met with that additional stigma, and it becomes really clear really quick because move-ins get slowed down, or we hear stigmatizing statements, calling, the parents addicts, or a lot of the names that they will utilize to address them. And the way we combat that is through direct supervision in parenting sessions from a LCSW. So for myself personally, if we have specifically males are typically the ones that we meet the most resistance with. If I can identify that a guardian ad litem is trying to slow down a transition or a child being potentially reunified, those visits between that parent and child will be directly supervised by me. I will send out a descriptive letter for every single visitation on what I observed and what the parent is working on, any interventions I applied, or any support that the parent may need, and so on and so forth. And that tends to combat in court in a lot of ways some of that discrepancy of someone saying, well, this person is unfit and they can't do this, when we have a lot of documentation that proves otherwise.
Thank you so much for answering my question. That was really well spoken and thought out. And then I do see in the chat there is someone just commenting that they have a trainer who's starting to offer the TBRI caregiving series to parents of children. We would love to make it available to your families, so I can connect you to. And then Stephanie saying
Absolutely.
thank you for the work that you do. And she said, P.S. We are with Utah Foster Care. And then I see that Kurt has his hand up. So Kurt.
Yeah, thanks, Amy, for a great presentation. It sounds like an amazing program you have running there. It always is interesting to me on a side note that people that are in treatment get stigmatized when those who aren't in treatment, because people don't know about it, they just fly under the radar. And I think it's great that people do come for treatment and feel bad about the stigma that's out there because they are trying to better their lives and trying to do a little bit better. But my question was about your funding. It sounds like a very involved program, very I don't know if I'm sure it's funded through someone. So question one, what does your funding come through? And do you have a lot of volunteers, or are they all paid professionals that work in your program? How does that all, kind of the structure of that from an administrative type standpoint?
Yeah. The majority of our clients are Medicaid funded. So we're taking a look at like targeted adult Medicaid, Optum, Select Health, and Molina also offering some Medicaid. And then occasionally we also get some parents that have their own private insurance as well. But the majority of our clients are Medicaid funded. And then while we do have positions for volunteers, the majority of our staff are paid staff members, and we navigate that both through the fee for service, and bed rates. So we get like the day rate for our adults, but our kids are both bed rate and fee for service. So we kind of navigate that. I will say that, our program is supported by the remainder of our programs as well. It is seen as a mission, because a lot of our adults would probably not be in our adult programs if they had access to a program like ours. And if we could get rid of child abuse and neglect, I'm not sure a need for my program would exist at all, which is the social work life goal, right? To put ourselves out of business.
Thank you so much, Amy. We really appreciate your time and with you for presenting it for us. And I really, really enjoyed your presentation. And I think that Odyssey House is doing some really great, great work. So I think we're going to move on to our community question slash case presentation. I won't go over all of them, but they are split into three themes. I think the first room will have transitions, the second will have resiliency in families, and the third will have resources. So yeah, breakout rooms, if they're ready, we can go into them. So I'm pretty sure everyone's back because I did leave the timer running out. So yep, and Tori's nodding her head. Everyone is back. So I think we can share some ideas. I think we still have a little bit of time left. So Janelle, what kind of ideas were you guys talking about in your breakout rooms?
So we took on some questions about transitions and then the resiliency in families. And at the very end, I asked everybody one thing they were going to change in their practice. And so they really talked about consistency and making sure that you are there, being present, helping the families and individuals with that stabilization, doing some transparency about what is going on, and just supporting those parents because we know as we support parents, the children are better off.
Awesome. Thank you. And then Kurt, what kind of things were you guys talking about in your breakout room?
He was in
Or
my breakout room,
Oh,
so
really?
yeah,
Sorry.
that's
Who was
okay.
in the second breakout room? I think it was Tiffany.
Nope, you and Lisa. We
Oh.
combined. Kurt came in
Oh, okay,
number
okay.
group two
Sorry
joined
about
us.
that.
But
Yeah.
we,
I'm reading the case questions,
right,
but
I know I messed you
I
up on
think
that one.
then I'll just go on what our group was talking about. We had kind of a lot of talks about resources, and I think resources and kind of advocacy within kind of substance use within the family. And I think something really impactful that was said that is when families are taught to advocate very early on throughout the Odyssey House program, that naturally when they can advocate for themselves, they start to advocate for their child in return as well. And I think that's really wonderful and just a lot of resources were given as well. So I think it was some great suggestions. And then does that mean we didn't have another room? We only had two rooms? Okay, awesome. So then I guess that will be the end of our session. Just make sure that you guys, if you want that certificate of attendance, make sure to take that survey. The survey link is being dropped by Tori. It's been in the chat. And also make sure if you want to look over those case recommendations in the future, you can email projectscope@usu.edu to get an invite to our Canvas page, and you can view all of the additional resources and case recommendations on that Canvas page. And also make sure to attend our next substance use echo session. It'll be happening on December 10th. It is going to be on trauma-informed treatment presented by Jamie Meekum. So I hope to see you all there. Thank you guys so much for a wonderful session, and thank you, Amy, for taking the time out of your day to present for us. So have a good one.